Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Measles, an urgent call to action for child health providers. I'm Carolyn Byrne, Director of Governmental Affairs and Community Relations at the Alabama Department of Public Health. If you have a question about anything being discussed today, please email it during our broadcast. The email address is on your screen now and will appear again later in the program. Also, the handouts and continuing education materials are all available online. However, you will need to register for this program in order to access those materials. CME credit and continuing education credits for social workers have been approved for today's program. CME credit is provided using the Children's of Alabama Cloud CME online platform and mobile device or tablet app. The QR code and event ID are on your screen now and can also be found online. Attendees have until Tuesday, June 16th to record attendance and complete the evaluation. For social workers to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. No partial credit will be awarded. For social workers, while content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on June 30, 2028. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. And now I would like to welcome and introduce our presenter as we get started with our program. Dr. David Kimberlin is past president of the Pediatric Infectious Diseases Society and editor of the American Academy of Pediatrics Red Book. He is also a distinguished professor of pediatrics and the Sergio Stagno Endowed Chair in Pediatric Infectious Diseases at the University of Alabama at Birmingham. Welcome, Dr. Kimberlin. I know you have a lot of great information to cover, so let's get started.
Well, Carolyn, thank you very much for the opportunity to be here today. To all of ADPH, 150th year anniversary this year, which is a tremendous achievement and accomplishment, and so important when we think about keeping Alabamians safe. I also want to express my gratitude to the state chapter of the American Academy of Pediatrics. I think that all of us that are in the field of pediatrics, take care of children, care about children, have grandchildren, anybody is going to be interested in this topic. It's one that I wish we weren't talking about. It's shocking to me as I near the end of my career that it's coming full circle to where things were when I was an intern and a second-year resident in 1989, 1990, and 1991, when we had tens of thousands of cases of measles across the United States, including in Dallas, Texas, where I was training. And this is something that unfortunately is quite likely to happen again. We're going to go through a lot of materials as it relates to measles. Hopefully you'll walk away an hour or so from now with more information, more knowledge, more tools to be able to address what is likely to be an emerging infection for us. I guess I should say a re-emerging infection, one that we didn't have to face, but here we are. So disclosures, this is a pediatric presentation, so there will be off-label indications or discussion of medications. I always have this as part of my disclosures. My funding for my own research is all through the NIH, and occasionally, rarely, an industry-sponsored study where the monies go straight to UAB and not to me. We have a number of learning objectives that you've seen, and hopefully we'll be able to touch on these as we move through the presentation. So Probably not surprising, I guess, since you're joining this talk. 2025 was a pretty big year for measles. You can see on the slide that we had 2,286 cases across the United States. If your eyes drift to the left on this slide, you can see that the last time we exceeded that number was 1991, when I was a second-year resident. So that's a daunting kind of thing to realize, that what should have remained in our rearview mirror is now very much in the lanes in front of us, and maybe something, and likely will be something, that we encounter over the next several years. I do want to point out, though, as you're looking at this slide, it is important to recognize that we have the highest number of cases in more than 30 years. But I also want you to look at the years on the far left, where you can see the break in the y-axis, and we jump up into the tens of thousands of cases. Look at how rapidly we went from exceeding 10,000 cases down to maybe a couple of hundred cases within just a 2-year period of time. That was not by accident, folks. This was by design. This was by careful public health attention, and employed the activities and utilization of pediatricians and practitioners across the country to make it happen. And here's where the changes occurred. With the 1989, 1990, 1991 epidemic of measles, we recognized that the preceding recommendation of a single dose of MMR vaccine was not adequate to keep measles fully in check. And it wasn't because the measles vaccine was waning over time, was fading out or failing over time. Rather, it's because some children, a small percentage, but some children do not have an adequate response after one dose, and therefore require 2 doses of MMR vaccine. Once this was recognized and a universal second dose MMR recommendation was made, we started seeing cases fall. In addition, vaccines for children, the VFC program, what it allowed pediatricians and pediatric caregivers across the country to be able to do is to make it easier to access vaccines. That is critically important. It's especially important as we live in 2026, where some of the access to vaccines may be at risk going forward. And finally, you can see the overall effects by the time we got to 2000, just a mere decade after the highest of cases that we'd seen in many, many, many years. We reached elimination status in the United States. Now, what does that mean? You see additional, dark bars, very low dark bars, but nevertheless bars to the right of that elimination status. Elimination status does not mean no measles. What it means is no continued spread of measles within the United States. So there can still be, because measles is everywhere in the world, and everybody in the world is within 18 hours flight of where we are right now in Montgomery, Alabama. Because of that, at any moment in time, a measles case can be imported. What you want to have, though, is a strong enough barrier around that so that if somebody does fly in from a different country, brings in measles to the United States, that your children here are protected. And if your children are protected and your neighbor's children are protected, then over time, that 1 or 2 cases that come in, they burn out. They don't have continued transmission across populations. So that's where we reached elimination status. You'll see some things later in the talk that show that we're at risk of losing that elimination status. We have decreasing MMR rates. You can see, and I'll say with measles is incredibly infectious. It's like a heat-seeking missile. It will find the person in a room, in a community, in a neighborhood that is not fully immunized, fully immune to measles. It will find that person and it will infect them. And so with that kind of a infectivity, you have to have very high vaccination rates to protect communities. And that threshold is about 95%. We were at that just not long ago, 2019 and 2020, as we started the COVID pandemic. And you can see what's happened since. We've had a steady decline. This is in U.S. kindergartners with 2-dose MMR coverage, such that now we're between 92 and 93%, at least as of the 2024-2025 year. Now that's the bad news. The good news is if you look at Alabama, we're doing pretty well. Now, does that mean we're doing pretty well across the state? Arguably not. We'll talk some about how local communities, small areas, a matter of a number of square blocks within a town, can have lower immunization rates and therefore have populations at risk. But overall, as a state, we're doing better than much of the rest of the country, and that is something we should celebrate. We have a lot of vaccine buy-in among Alabamians, not as much as we need, but a lot more than other parts of the state frequently face. And that's a strength, something we can build on, something we can relate to our patients and try to connect with them and make sure that they continue to make the good choices of fully immunizing against measles, against pertussis, against the other vaccine-preventable diseases. Well, let's talk some about 2025. I've already, shown the almost 2,300 cases that we've had, and what this map does is show in the blue circles the outbreaks of measles in the communities. And of course, we remember the West Texas outbreak along the right up next to the border of New Mexico. That one spread, and you can see, if you might be able to see a very small red dot in the middle of that, and it spread out from there. In addition, Spartanburg, South Carolina was a center. It also started with an imported case that then began to spread because of lower vaccination rates in the community and spread to neighboring states as well. And then the other part is the Four Corners area, kind of especially along the Utah and the Arizona border. And this is something where we have continued concern for ongoing spread at the current time. So that's one of the things I want you to look at with this particular slide. There's two additional things as well. One is along the Mexican border where El Paso is and right up next to New Mexico. Watch that blue dot as we move into the 2026 map in a few slides. The other thing is look at the number of red dots on this map, and those are the imported cases measured in 2025. It's like shotgun pellet. This is across the United States where, and I'm talking, not just the coasts, not just the places where, major airports are. This is in areas of the country where normal Americans live, do their hard work, and every single day are trying to do right by their families. And we need to make sure they have the information that they need to make sure that they make the right decisions for their children, and which means to get vaccinated, and that we have vaccines that are accessible to them when they choose to take that path. Now, looking at this a little bit further, the 2025, 93% of the cases of those 2,286 cases, 93% of them were in people who were either unvaccinated or had an unknown vaccine status. 11% were hospitalized, and there were 3 deaths in this outbreak of this calendar year of 2,286 total cases. That comes out to about 1.3 deaths per 1,000, and you'll see that on a subsequent slide that the average number of deaths in measles is about 2 per 1,000. So we're seeing in 2025 what we saw back in the 1980s and the 1970s and the 1960s, and certainly before that, before we had MMR vaccine. And that is that children primarily will die from this. And in addition, there'll be some other long-term sequelae for some rare survivors of measles as well. The other point I want to point out here that I want to make is that for us, this is a continental issue. It's not just the United States, but also communities in Mexico and in Canada. For example, the cases that were in West Texas were in a Mennonite community. That was where the population was. And there are similar Mennonite communities with relatives in northern Mexico and in central portions of Canada, and many of the folks would travel back and forth to see their relatives. No harm in that, but they would be going to these other areas, and if they are under-vaccinated, it raises the possibility that it can spread across Mennonite communities, which in fact is what we did see in 2025. It is unusual to have measles cases. It is incorrect, factually erroneous, to say that measles outbreaks are not unusual. You could have seen on the slide where the bars after we got down from 2000 or so, the very low bars on the prior graph of total cases by year. Those are not normal. What we're going through is not normal. And it's wrong to say that it is. Children are dying. Families are seeing a coffin be lowered into the ground with their child in it because of a lack of vaccination and a decision not to vaccinate their children. And we need to be very mindful about where the correct information is and where the misinformation is. This is not a dietary thing. This is not a poor health choice thing other than not getting vaccinated. This is simply that we're not using science or we're not using medicine in a way that I think God gives us a mind to do. You know, there's a reason that Luke in the Bible was a physician. There's a reason that physicians are venerated in biblical scripture. It's not wrong to take advice from sound, reputable healthcare providers. And yet right now, I think we have other voices in the room, very loud voices from very big platforms that are deliberately trying to make things difficult to understand. So here we are in 2026. We already have 1,600 plus cases here this year. So we're 70% of the way to the end of 2025's numbers. And yet we're only, 4 months in by the time this map was done in early April, or really just over 3 months in. Big areas to watch right now, the Spartanburg, South Carolina area. That does seem, more recent data suggests that the sustained transmission is no longer being seen in that community. That's a good thing. And it's really that Utah, Arizona border where there's a lot of interest, a lot of focus right now. Now, I want to point out two other things. I've already had you draw your eyes on a prior map, the 2025 map, to that El Paso, New Mexico area down in the southern part of the U.S. And I want you to look dead center in the top, right where North Dakota and Minnesota come together, and see that other circle up there. And it's going to be important as we move in over the next handful of minutes into discussions of where cases are in Mexico and in Canada. It's not going to be coincidental that we're beginning to see blue areas in those two regions of our United States. Let's talk about Canada. 2025, and Canada, has a much smaller population than the United States. They had in excess of 5,000 cases. And when you look specifically at regions of the country, Manitoba, right in the middle, had 600 plus cases. This is right above the border of North Dakota and Minnesota. And that's the reason I wanted you to be looking at this. This is measles. No infectious disease is mindful of national borders. We learned that with COVID. We didn't want to believe it. It's true. It's certainly the case with a disease that's as contagious as measles is, and we see that with movements of population across the northern border. In the southern, south of the southern border, we have cases in Mexico. In 2026, we're already looking at a 10,000 case kind of number in Mexico, and you can see some of this is by month. So if you look at it by week, you can see this classic epi curve with a peak, and thankfully cases are coming down, but we still are at much, much higher cases than baseline, just even from 2 years ago. And if you look at a map of Mexico, you can see the northern state of Chihuahua, where there is a lot of dark shading. That is a major area, and it just happens to be immediately south of El Paso and where Texas and New Mexico meet. Again, not a coincidence here. And then Jalisco as well, which is kind of on the Pacific coast, about halfway down, just below the Gulf of California. That is another area where there's a lot of measles cases in Mexico. Let's talk some about the virus. It's an RNA virus. Interestingly, and we always think about, like with Mpox and with Ebola and with other things that get a lot of news, and appropriately so, about the jump from an animal reservoir. Well, thousands of years ago, a similar thing happened with measles, and it came from a spillover from cattle. But subsequently, the virus evolved and developed such that it only infects humans. Humans are the only place where measles virus can persist, can survive, which really does give us, now we're a long ways from thinking about worldwide elimination. We're going the wrong direction, not the right direction, but it does raise the possibility that, yes, one day our great-great-grandchildren might live in a world where measles is like smallpox and we never knew it, and it's just a historical memory. It's spread through the air, and this is one, you remember during COVID, there was all the, hoopla about droplet versus airborne, and it probably is a continuum. This one actually, measles actually hangs in the air for hours. So if somebody in this room were shedding measles right now and coughed, it would hang in the air for up to 2 hours after everybody's left the room. And so if somebody then comes in who's not immune to measles, comes into that room an hour, hour and a half later, they still can get infected, even though the source case in this hypothetical example, even though that source case is long gone, is back home or at the pool or doing whatever. And it is incredibly contagious. The R naught terminology that we heard about so much with COVID, about how many people who are uninfected become infected from a single source case, with measles is in the 12 to 18 range. And about the only other virus that is close to that would be chickenpox, which is in the 8 to 10 range. Now, interestingly, you may remember COVID initially was in that 10-ish range for the R naught, but that was predicated on a couple of things during the early days of the pandemic. Number one, nobody in the world had ever seen it before, so there was no, population immunity to it whatsoever. Everybody was at risk. And number two, it was an earlier version of the virus. It was an earlier strain of the virus that has adapted since then to still cause a lot of bad disease in people, but it's not as virulent in most people, or our levels of immunity with COVID are up high enough that we're not seeing the kind of devastation that we did back when we were trying to flatten the curve with masking and so forth. And masking does work, by the way. All right, let's talk a little about what measles looks like. After exposure, a week and a half, 2 weeks pass while there's incubation period. And then a patient will develop a prodrome that will last 2 to 4 days. And in that prodrome, they'll have fever, they'll have the 3 C's, cough, coryza, conjunctivitis, and they may have Koplik spots. And I've got a picture of that. Koplik spots are these, it looks like little grains of salt on the buccal mucosa and the pharynx if you look into the mouth of a patient that's during this prodromal period with measles. Fever, the 3 C's, Koplik spots. And if you want an image, a mental image of this, if you've seen measles, you know what it looks like. It's one of those things like, I've seen it, I know. But if you haven't seen it, number one, you will, and number two, it looks like a really bad case of Kawasaki. It's that kind of miserable, red eyes, rash, it's just a look. And so if you see something like that and you're thinking, this could be Kawasaki, be thinking, and it could be HHV6, roseola, that would be another one. Although measles and Kawasaki, so that miserable component to it is something that's hard to quantify, but it is something that qualitatively, I think, can hold in many cases. And then you move beyond the prodrome and you develop a rash. It's a morbilliform rash, starts on the face and on the neck. It spreads down and out to the trunk and to the extremities. And then what starts out as kind of macular and macular-papular becomes confluent and then will fade in that same order of appearance. So the important thing here is to recognize what it looks like, to be very ready to respond, and have your plans in place in your practices about what you're going to do when somebody with a rash comes in, a rash that might look like measles comes in, and how you're going to respond to that. So you're not scrambling at that particular time. Have your standard operating procedure set so you're ready for it if and when it happens. And then the other thing that makes it really interesting and challenging from the standpoint of measles is that you can be contagious from 4 days before until 4 days after the rash. And so after the rash, probably pretty easy. You go, there's something wrong with that child. But before the rash, keep in mind, this is the prodromal period, and you might not have that kind of miserable look that you're going to get as you move into the rash phase. And the fact that it can be contagious during that period of time makes it difficult to contain when it does hit a vulnerable population, a population where fewer than 95% of people are immune to the virus. Some pictures. Clinical measles, what the rash can look like. We're not allowed to show eyes anymore, so I can't show you what the conjunctiva look like, but you can go to the Red Book online, and we have some pictures there as well that that will give you, kind of that mental image. And we have it in a variety of skin colors as well, so not just white kids, but black kids, Asian kids, and so forth. Important to recognize it across the population that are our neighbors here in the United States. And here is the Koplik spots, little tiny grains of salt is what, again, that's what it looks like. I can see them better on the buccal mucosa, and back in the early 90s when we were seeing a ton of cases in Dallas, that was where I would say I'd get a tongue blade, pull it out like that, and you can see the little dots over there, and it's highly suggestive of measles. Let's talk about complications. Diarrhea, otitis, pneumonia, those are the most common things. Anywhere from 5 to 10 or 15% of people will develop those complications. Pneumonia can be either a direct pneumonitis from the virus, or it can be a secondary bacterial infection upon damaged mucosa, mucosa that's been damaged by the virus, but sets up the opportunity for a bacterial superinfection. You can see that about 0.5% of people will have seizures, 0.2%, that's 2 out of 1,000 that I mentioned before, will die. And then you can have a primary measles encephalitis in the same 2 per 1,000, or you can have post-infectious encephalomyelitis in about half that number. So we're talking rare, no doubt about that, but if we're talking tens of thousands of cases, it's likely that somebody in a given area is going to eventually come into contact with a situation such as this. And then there is a condition called subacute sclerosing panencephalitis, or SSPE. It occurs in about 1 in 10,000 cases, but if you acquire measles, wild-type measles virus at a very young age, under a year of age, instead of 1 in 10,000, it's about 1 in 600 who subsequently will develop SSPE. It's happened recently in the United States, over in Los Angeles. A child who acquired measles prior to a year of age was diagnosed and subsequently died from SSPE. And I want to spend just a moment and talk a little about it. It's rare, but it's a degenerative disease. I've seen it one time only when I was in fellowship training in Dallas in the mid-1990s. A child from India who did acquire measles, wild-type measles disease early in life, within that first year of life. And then he was about 11 years old, if I remember correctly, when we were diagnosing with SSPE. There's nothing that can be done for it. You just watch these children regress and fade, and it's terrible. I mean, it's kind of like rabies, kind of bad, although it takes longer. It's a slower, more miserable death than that. I've already mentioned that higher rates and faster onset occur when a child is infected with wild-type virus before 2 years of age. And it's not related to the vaccine strain. It's only wild-type virus that can do this. And what happens, it is kind of interesting from a virologic standpoint. The virus mutates in the brain. The brain is a relatively protected environment, and it allows ongoing replication of the virus. And the virus ultimately becomes replication defective. So it continues to cause disease within the brain tissue, but doesn't spread to, back out to other parts of the body. So, but it's not, if you were to do an autopsy on these cases, and you sequence the virus or something, you're going to see that it's a defective virion, not the same wild-type virion that caused the disease, measles disease, so many years prior to that. No treatment for it. The only way to prevent it is to get vaccinated, because if you get vaccinated, you never get measles. If you never get measles, you never are at risk for SSPE. Now, in addition, measles has a unique propensity, a relatively unique propensity, to really do a number on your immune system. So you can see in red on this slide, the left-hand portion of the slide, that represents the repertoire of immune responses or phenomena that a given person will have prior to getting measles. And you know, it's to the vaccine preventable diseases, assuming they've been vaccinated. It's for rhinovirus. It's for enteroviruses. It's basically any infection you get when you make an immune response. That's that box of red over to the left side of the slide. Then they get measles. And what happens is it sort of hijacks your whole immune system, and for a while, that's pretty much all your body's focused on your body's immune system is focused on is measles, and it lasts for years after that. You can see that the big red box becomes a thin red line extending out over time to the right, and then eventually, over those months and years, you know, either through re-exposure, revaccination, whatever it may be, the full repertoire of responses will repopulate, but it leaves somebody at risk for a long time for disease, from death for other things, simply because they had measles, you know, months or even years prior. And this is something that's been recognized in other parts of the world with regularity. When measles moves through villages in Africa, for example, it'll kill a lot of children, and it leaves, you know, others with encephalitis and permanent neurologic sequelae, and others, you know, with bad lungs from the damage from pneumonia and so forth. But then, you know, 6 months later, a year later, year and a half later, children are still dying. They're dying of pneumococcal disease. They're dying of Haemophilus or meningococcal disease, things that they might have had immunity to before, but they're left vulnerable because of what measles did to them. I've talked a little about differential diagnoses already. Kawasaki disease is that mental image that helps me so much when I'm thinking about measles. But we've also got to think about HHV6. That would be roseola. You got to think about dengue and scarlet fever and parvovirus, rubella, maybe some of the enteroviruses as well. The rash can be atypical. It can be even absent in immunocompromised patients. And so much of this is going to be through the history. What is the vaccination status of the child? What kind of exposures do they have? What are the beliefs of the communities they live in? Because that will have a real impact as well about what their likelihood of having been exposed to measles is. In terms of diagnoses, you've got a serologic approach and you've got a virologic approach. For serology, you're going to want to get IgG and IgM. IgM can be negative early during that prodromal period, or if you're more than a month out from measles, but you should still see a fourfold rise in IgG. And you're going to want to get a oropharyngeal swab as well as urine for PCR for measles RNA, a reverse transcriptase PCR. So you want to get blood for serologies. You want to get urine and the throat swab for RT-PCR viral culture. You could do, but it's very rarely done anymore. And one of the biggest things is the third bullet down: call for help. And the state health department, your county health department, they will be ready to be right there at your side and walk you through this. There's, you think two things: isolate and call. And of course, ABCs, make sure the child's doing okay health-wise, and not having an imminent crisis. But then you're going to want to think about what kind of host status you've got, what the measles immune status is, what the exposure risk is, including local epidemiology as well as travel. And you're going to want to obtain tests. You can find a lot of this information on the ADPH website. But again, no reason for you to be clicking around on the, except other than to get to your local county health department or the state health department phone number to give them a call and get the experts that are sitting with me in this room on the phone, so that you can really have that kind of guidance in terms of how to manage that particular situation. There's no specific antiviral therapy. Ribavirin, which has been a drug for decades now, looking for a disease. Ribavirin has some in vitro activity, and when those cases were of hospitalized children in West Texas were coming to the attention of CDC, I was on the phone with them last June when I was over in Texas, not in West Texas, in Austin, and we talked through ribavirin, and ultimately I think it was tried, but whether it has any effect, I don't know. But that's where the tertiary and quaternary medical centers that will be helping you take care of these patients can help with that. And of course, if you do have a bacterial superinfection, pneumonia, as I've mentioned, otitis media, you're going to want to treat that with antibiotics. Now, vitamin A is something that you've heard of, and there have been recognized, you'll see on the next slide, since the 1930s, recognition that for children that are vitamin A deficient, they have increased rates of complications of measles. And that's, it's also been documented in numerous randomized control trials that if you supplement those people who have vitamin A deficiencies, they have better outcomes. But vitamin A is not a treatment for measles. Vitamin A helps restore the immune system where it doesn't get hurt as bad from measles. So it's an important thing to do, but it's not like, taking, amoxicillin for an otitis media or oseltamivir for influenza. It is not virus specific. The only way to prevent measles is to be vaccinated with MMR. And then post-exposure, you can give either vaccine or immune globulin, depending on the age of the child. We'll have a little bit on that here in a moment, as well as their vaccination status. So let's spend a little bit more time on vitamin A. This was really debated a handful of years ago now by the Committee on Infectious Diseases of the American Academy of Pediatrics. We don't have much vitamin A deficiency in the United States, certainly not compared with the rest of the world. But WHO does recommend universally vitamin A for all children with measles, not just children in middle-income and lower-income countries. It's all children with measles, regardless of the country of residence. And that's really been embraced by the AAP. I don't know if somebody's vitamin A deficient. Vitamin A, when given at the correct dose, is a very safe treatment intervention for those that might be deficient. And so the recommendation is to go ahead and give vitamin A. And you can see where some of these data came from. Ellison was the one who first made that observation back in 1932 about the increased risk of pneumonia and death correlating with lower vitamin A levels. And then less mortality with higher vitamin A concentrations. So U.S. data suggests that measles infection can lower circulating vitamin A levels as well. So it also has potentially that benefit of shoring up the vitamin A in a given patient's body if they're struggling to get over measles as well. You give once daily dosing for 2 consecutive days, so 2 doses total, 1 on day 1, 1 on day 2. The third dose can be 2 to 6 weeks later, but that's only if you're looking at clinical signs of vitamin A deficiency like xerophthalmia. There's no role in using vitamin A for the treatment of measles other than this kind of a prophylactic or preventative utilization. And you can see the dose range. It's an international unit dosing or an RAE, depending on your source, micrograms per RAE. But you can see what the dose is if you're under 6 months, if you're 6 through 11 months, or if you're 12 months of age and older. There were a number of vitamin A toxicities in West Texas. My understanding is that people were out there hawking liver, sales of liver, and so, generally, it's better to get health information from healthcare professionals and not follow these kind of snake oil salesmen. So be wary because vitamin A toxicity is a real thing. If a certain amount of vitamin A is good, that doesn't make 8 times that amount better. It makes it toxic. And so you want to make sure you're following the doses that I showed on the previous slide and that are available in the Red Book, and they're available in CDC's website, and they're available in WHO materials as well. Well, I've touched on some of this already about what we've learned over the last 60-plus years with measles vaccination. Measles can be eliminated. We succeeded at that in the United States, but it requires a really sustained campaign. And it requires high vaccination coverage rates at or above 95% in order to keep this heat-seeking missile from finding the vulnerable person in that population. Well-enforced school vaccination mandates are crucial to this, and this is being weakened, countrywide. State legislatures are backing away on some of these vaccine mandates within schools under the guise of parental rights. Well, I would argue that a parent has a right to have their child be alive, and that what another parent decides to do with MMR if they choose not to get it, puts their child, that other person's child, at risk. So I do get individual rights. I understand the argument, but this is not the disease to do that. Hypertension might be a disease to do that, or cardiovascular disease or something like that, where if someone in the audience here chooses not to treat their hypertension, it ain't going to bother me, except when I'm, mourning their loss from a stroke or something, but it's not going to directly put me at risk. Infectious diseases, especially ones that as transmissible as this, that's a different entity altogether, and I think it's a different argument. At least that would be my position here. 2 doses of MMR vaccine are needed. You can see here that about 93% of children will be protected after a single dose. But then in order to get that other, 7%, 5 to 7%, you need that second dose so that they have a primary immune response to the vaccine itself. And then once you get your 2 doses, you're protected for the rest of your life. You need a well-functioning state and local health department to be able to respond to these things. You've got to have eyes on the ground. I mean, look at Ebola right now, what's going on over in Africa. Part of the reason it's exploding into the biggest Ebola outbreak ever, not quite there yet, but that's the direction it's heading, is because there were not eyes on the ground. People had pulled back from these areas, and I'm talking USAID and other entities, but in addition to that, there's a lot of civil strife in this area. So even before the pullback, these were hard areas to reach. And if you don't have eyes looking for things, then stuff spreads before you're able to respond to it. And then you're playing catch up. And if you're down 4 touchdowns in the fourth quarter, you're going to have a hard time catching up. In addition, you need stable funding for vaccines. This is the VFC program that I was talking about. More than half of children in the United States get their vaccines under VFC. We need a good functioning ACIP to have VFC work ideally. And so this is something where you invest, It's kind of boring investment, but it's what you need to do, because if it works, you never see the benefit, which is the disease you're preventing. You never see that disease. Because it works, because vaccines save lives. And anti-vaccine misinformation threatens all of this progress, in case you didn't pick up on a theme I've been kind of sprinkling throughout this presentation. Routine vaccination begins at 12 months of age with the second dose at 4 to 6 years of age, but you can give that second dose anytime as long as it's 28 days or more after the first dose. You can use MMR or MMRV. There is an upper age range for MMRV. And so, either of these is perfectly acceptable. AAP recommends MMRV as a generally preferred second dose because it's a combination vaccine. So you have fewer shots. But if you wanted to do MMR plus V for that second dose, that's fine. And there's no preference for MMR plus V or MMRV for the first dose. Now, this could change a little bit, at least coming out of ACIP. They've kind of flirted with the idea of taking up that MMRV dose for that first dose. And with all the dysfunction at ACIP right now, I'm not sure what's going to happen with that, but it is something to keep your eyes open for. But even if MMRV goes off the table, you got MMR plus varicella vaccine. And then discuss rare possibilities of febrile seizures. These are like 1 in 2,000 or 3,000 kind of events that occur with that slight increase more frequency with MMRV. Compared with MMR plus V. For dose 1, there's no difference in febrile seizures following dose 2. In terms of catch-up, I've mentioned that second dose can be given at least 4 weeks apart, and based upon guidance from your local health officials, your public health officials, when measles is spreading in an environment or a community, there can be recommendations to give that second dose for the children that have gotten it at 1 year or 12 months of age, to give that second dose closer in. It's not right now routine standard care, but listen to local public health advice, because it is possible as measles spreads, and it likely will spread across the country, that may be a recommendation. For international travel, you can give the first dose of the vaccine at 6 through 11 months. That's called the 0-dose vaccine, because you still need 2 additional doses after you turn 12 months of age. Interestingly, how do we handle local outbreaks? You know, my daughter is a school teacher over in Greenville, South Carolina, which is about 20 miles away from Spartanburg. And so what do you do if you have somebody going to a hot spot in the United States? And we're struggling with that. We don't know what the answer is right now. But again, some phenomenal public health folks at CDC, at ADPH, at the local county health departments are looking at this, thinking about this, and will give guidance as we move forward. Let's talk a little about post-exposure prophylaxis. It's predicated upon the age, the measles immune status, and time since exposure. This is a table that was initially adapted from a New York State Health Department graphic. It's in the Red Book. It was in the 2024 it was actually in the 2021 Red Book as well as 2024. It will be in the 2027 edition also. And you can see age on the far left column. These are for people that are not pregnant and that are immunocompetent. And then you can see greater than or equal to 6 months. If they're immune, then there's nothing more that's needed. If they're greater than or equal to 12 months and they've had a single dose of MMR, then you give another dose of MMR, and you can work your way down here to see whether, if you're still within that 0 through 3 day window of time, whether a vaccine would be the better way to go, or if you're 4 through 6 days out, whether gamma globulin would be a better way to go, either IgIM or IMIG or IVIG, either of those, if you're in a gamma globulin window here, and what to do in terms of quarantine and isolation, again, based upon age, time since exposure, and vaccine status or immune status. And then if you look at pregnant women as well as immunocompromised host children or adults, you can see what the recommendations here are as well. And I do want to, I will make the point down in that lower box. If you give immune globulin, then for the live vaccines, you've got to wait certain periods of time, depending on how much immune globulin is given, before you can give a live vaccine, because otherwise they've got antibodies circulating because of the exogenous immune globulin they received. So you've got to wait, even out to 11, 12 months, depending on the dose, before you can give a live vaccine again and have the immune system be able to see it and have immune response to it, as you want it to do with a vaccine. Quarantine is represented here. You need to wait 21 days after the rash, after the last exposure, if somebody is non-immune. And then if immune globulin is given, it can extend that out to 28 days. And there are a number of recommendations for in utero exposure, and this is not terribly evidence-based because there isn't a whole lot of evidence out there of exactly what to do. But the gist of it, and this is a frequently asked question kind of portion of Red Book Online where you can get access to this in even greater detail, and we're going to put wording along these lines in the 2027 measles chapter in the Red Book as well. But if you're within 14 days, the woman delivers within 14 days, and of having measles, I guess I think I'm saying that right. Then in that situation, you got to consider the now newborn baby to be infectious and respond accordingly. And there are recommendations about giving immune globulin. Don't know if it works, but it ain't going to hurt, and it might help. So that's that recommendation. And then if you're more than 14 days between when mom got over measles during pregnancy and when baby is born, you don't have to consider the baby unless it's, extenuating circumstances like prematurity or so forth. You don't have to consider the baby to be infected with measles at that particular time. But it may be a situation where you still might need to have some isolation precautions. I've shown this slide before. What does the future hold? I'm on the committee, the U.S. committee that looks at the data for measles eradication to see whether it's called the National Sustainability Commission. to see whether we still are no longer endemic for measles. And I don't know what the data are going to show. We're going to meet later this summer and have a look at the data. I'm not optimistic personally, just speaking just from my own personal opinions because of everything you've just heard for the last 45 or 50 minutes. And our vaccination rates are going the wrong direction, not the right direction. And if you look even at the local population level, you know, not all states report this, but this is the country level 2-dose MMR rates by county. And look in on that far West Texas portion of the map, and if you zoom in on that, even though the county is in orange, that upper east portion of the county in the green circle that we've zoomed in on there is bright red, meaning at high risk. So even though the county itself might look like you're in pretty good shape, or at least not terrible shape, you might get, I'm making this up, you know, a 10 square block area of a town where the immunization rates are in the 40s or 50s, and that's going to be a problem. And measles will take advantage of that. It is a wily adversary, and it will find these groups, and it will get them sick. This is a modeling slide, and you know, as the saying goes, all models are wrong and some models are helpful. It does suggest running this, you know, this algorithm 2,000 times. It suggests with our current vaccination rates and kind of a window around those rates that it is really likely over the next 10 or 15 years that measles will reestablish endemicity, and that, you know, people that are beginning their training now will not get back to where I spent most of my career for a long time to come. That's the bad news. The good news is we know what to do about it. We know what works because it's worked before. And so what I would say is let's do that. You know, let's do what we know works so that we don't have to face this what may be relatively inevitable right now, but we can have a different future. And we hope that that's the case. Canada's already lost its elimination status. That happened last year. But if you look at Brazil, which lost their immunization status in 2019, they got it back by 2022 or so. So it can be done. It's just going to take a lot more hard work than if we had kept our guard up to begin with. And it's not just measles. Measles is the canary in the coal mine because of how contagious it is, but pertussis deaths are up. Other vaccine preventable diseases are resurging because of this misinformation campaign, and frankly because parents are not making the right choice about getting their children vaccinated, or maybe they want to get their children vaccinated and they don't have access to the vaccines in their community, or they make it so hard you got to take off work for several days in a row to find out where to go. We don't have to do this. We can do this better. And I think that all of us, if we roll up our sleeves and if we make our voices known to the leaders in Montgomery, the legislative leaders, we have a functioning, stable, good democracy. They'll listen to our voices, but we got to say it, and we got to probably say it less passionately than I've been saying this. You probably need to be a bit more dispassionate about it, but you care about the children you take care of, and parents care about their own children. They just need help making the right decisions to keep those children safe. Vaccines have saved 154 million lives. 154 million lives in the United States. And this is tetanus, measles, whooping cough, tuberculosis. 154 million lives. They work. We don't see these diseases anymore except for the resurging ones because of the vaccines. We don't need any more proof than that. So what are the take-home points? Highly contagious disease. It can cause severe disease. It can cause death, especially in unvaccinated, unprotected children. Falling vaccination rates nationally and at the local level are driving these outbreaks. If you suspect measles early, isolate, get your diagnostics, call phone a friend with the health department. Consider vitamin A if you're thinking it's measles. Doesn't hurt to give a dose of vitamin A at the amount that's in the red book and on the slides I just showed you. Timely use of post-exposure prophylaxis. It is time sensitive. You know, that 0 to 3 days gives more options than the 4 through 6 days do. And alerting the public health folks, as I've already mentioned. And then finally, acceptance of vaccination by the public is the only way we're going to get out of this mess. We can't. The true believers on this call, myself included, we can't fix this. We can play our role, but ultimately we need to be persuasive, respectful, and find ways to connect with people who are trying to do the right thing. And how each of us handle the individual conversation, and from one conversation to the next, that's going to be part of the fun of these next few years. I thank you very much for your attention. I'm happy to take any questions we may have.
Thank you so much, Dr. Kimmerlin. That was such an informative presentation. And I do want to encourage the audience, this is a wonderful opportunity to have such an expert, worldwide expert here with us to ask any questions. So we will be putting an email address on the screen so that you all can ask questions. And I do have a question.
Yes, ma'am.
When you work with the public, there's a lot of misinformation, as we talked about. But sometimes I hear that natural immunity is safer than the vaccines. How do you address that with your patients or with your colleagues?
Natural immunity, I like to call it infection-induced immunity.
Okay.
Because there's nothing natural about 3 children or two children and an adult dying of measles. That's not natural in the United States anymore, or maybe it's coming back. But but infection-induced immunity can generate immunity, and it puts you at risk of dying, or having SSPE, or having one of the other more common complications of measles. Why?
Right.
Is my answer. Wouldn't you take the safer route? Wouldn't you take the preventative approach? I don't know if this is the best kind of. I use it a lot. I'm not sure if it works or not. I honestly don't know. But when you get in your car, every single time, and if a big audience, I'd say how many folks, drove to buckled their seatbelt before they got
right.
As they got in the car and drove to work. All the hands go up. How many people have been in a wreck in the last month? And there's maybe one hand that goes up. Mm-hmm. And I said, well, you guys you're wasting your time. Think of all that time you could have saved for this past month if you hadn't buckled up.
Right.
But you don't need it till you need it. And that's what vaccines do for us, is they give us that opportunity to protect ourselves ahead of time with virtually no risks. Everything has risks. This water here, if I had a pan of it, and it keeps me alive, first of all, and if I drink an average normal amount of it, my sodium stays stable and so forth. But if I drink 18 gallons, I'm going to get hyponatremic and seize. Or if I put an inch of it in a tray and put my face in there and don't move my face, I'm going to die of drowning. Right. So everything has risks. But you got to weigh the risks, and by far, vaccines are safer than the disease that they prevent. So that's the approach I take. I guess let me back out one more thing. And I guess your question kind of alluded to this. The first thing I do when I'm sitting with a family that is, potentially vaccine hesitant, mm-hmm. is ask why. And I really mean that. I want to know why, because everybody has a different reason. It might be that, the brother, has autism, and they think vaccines might have caused that, which it doesn't. Vaccines do not cause autism. It's been shown over and 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 over again that they don't. But that family might believe they do. And that would be a different conversation than somebody who is just absolutely, has drank the Kool-Aid on vaccine risks, which, are not what they're learning about. Or they might, the hardest ones are the ones, and these are more common more recently. It's like, I don't know, I just heard something,
Yeah.
and I don't know what to do with that, because I don't know what their concerns are, and so I don't even have a chance to really respond to it. But I do think, I really do mean this, and you can hear, I think y'all could hear my frustration. I mean, sure. I've got to be honest with myself about it. But when I'm sitting down with the family, I pray that I don't have that, because they care about their child just as much as I care about my now grown children. And people are not bad people. We got to find ways to connect. And maybe I'm not the best ambassador for that. Certainly on some days I'm better than others. But all of us can try to hear where our neighbors are coming from, and then find ways to connect with them and have them reestablish trust with us. And as they do that, then we have a chance.
Sabra, do you have a question?
I do. I have one from Karen Landers. Dr. Kimberlin, as we know, single antigen measles, mumps, and rubella vaccines are not available in the U.S. Can you please address your response to parents who say they would vaccinate if only there were single antigen vaccines?
Well, there aren't. I was at this ACIP meeting. For 17 years, I was one of the AAP, the American Academy of Pediatric Liaisons to the ACIP. And when the company announced at the ACIP that they were no longer going to manufacture monovalent measles, monovalent mumps, monovalent rubella, they got a standing ovation because there's no need for them. MMR is safe, and it's 1/3 the injections, or the jabs, as people like to, who are disdainful of this would say. So you get the same benefit with fewer injections, and it's just a. Honestly, I think if many of the folks that say, "Oh, if only this, if I could do that, I'd do it." You give them that, and they're like, "Oh, well, I think it's this over here." I mean, it's whack-a-mole. You constantly, and at some point, you just got to go, the science doesn't show it. The evidence is not there. This is the way to do it. And this is, I don't know if it's going to be the right thing to say or not, and I'm being recorded, so I guess I might as well go ahead and just jump. It's okay to be paternalistic and maternalistic. It's okay. You went to medical school. You put the years in. You've seen what these diseases can do. It's okay to say, this is what you should do. Now, if somebody walks out and says, no, I'm not going to do that, then you're not going to, have them arrested or something. You obviously need to respect personal boundaries. But don't just say, hey, what do you want? Hey, anything goes. I'll give you measles and mumps and rubella separate. I mean, you're the professional, and you have the platform, and use it. It won't work with everybody, but it will work with some, because they'll see the passion in your eyes and in your voice, and they'll go, she really believes this. And I remember when she was up with my child that night in the hospital. I trust her. I'll do what she says. But if you're wishy-washy, it ain't gonna help. Yeah.
So you talked a little bit about communicating with vaccine-hesitant parents. How would you advise people, doctors or social workers, to go about communicating the more technical, science-y aspects of the reasons why you should vaccinate your child, without overcomplicating it, but also treating them as adults who know things and can make decisions?
Yeah, you aren't Mike, so I'm not sure if it picked up or not. But it's about vaccine communication, and what language do you use? So first of all, I'll say it again, respectfully. That's first and foremost. And hopefully sitting. If they're sitting, you sit. If they're standing, you stand. You're not over them. That creates a dynamic that is just bad vibe. I don't like it when somebody's lecturing me. So get down at eye level, be respectful, but leave all the jargon behind. They know you're smart. They know you're a doctor. You don't have to use, you don't have to talk about coryza. You use real words, and I really don't think that's talking down at all. I think that's talking normal. So that would be my recommendation.
So we talked about parents today have not seen these diseases and have not experienced how bad these diseases can be. How can our grandparents and great-grandparents get involved? What are some of the things you think they can do? Because they've seen the diseases, they have lived through it.
Yeah, that is an outstanding question. You know, I don't know that we necessarily can facilitate or enable that, but there are you know, advocacy groups that are grandparents, and I'm blanking on some of the names, but you know, it's not just families fighting flu, but you know, grandparents fighting measles. I'm not sure if that's one of them or not, but that literally grandparents is in the title of some of these groups, and I think that is tremendously powerful. I do think that, you know, we're in an odd place in our country's history right now, and to some extent, I think the issues of vaccine preventable diseases coming back relates to this. I think we don't trust anybody anymore.
Right.
We don't trust institutions anymore.
Absolutely.
We don't trust the medical institutions. We don't trust banks. We don't trust lawyers. We don't trust church. We don't. I mean, no, it's just, it goes on and on. And you know, should it be that way? Yeah, that's a totally different conversation.
Right.
It's just the way it is. That's reality on the ground. And so, who do you trust? Well, you trust your family.
Right.
I mean, hope anyway. Most people trust their family. And so I think so this could be at the individual level, if you're having a conversation and you do have a multi-generational representation in the room, involve everybody. You know, this is a dialogue, and what you may or may not find the grandparents wanting to step in. They might fear that the parent's not going to let them see the grandchild if they get too verbal, and that happens. Happens with pediatricians in Birmingham that have told me that with their own grandchildren.
Wow.
I won't give any names, but it's I mean, it's bad. But sometimes they will, and I think that kind of peer-to-peer advocacy is tremendously important.
Because we were thinking of ways to rebuild trust in a system where we have lost trust during COVID. I do have one more question that we get a lot from parents, and that is mercury in the vaccines. Can you address, that's sort of on a whole different topic now, but can you address that? Because parents are afraid, you know, that the mercury will cause problems with the children.
Yeah, the vaccines we have in the United States don't have any mercury compound in there,
Okay.
and the mercury component that was a preservative in multi-dose vaccines was not even the kind of mercury that causes any kind of neurologic toxicity. So this is just more noise. It's a very effective noise, but it's a non-issue.
Okay.
Now, in that whack-a-mole kind of approach, it became, well, it's not the mercury in there. It's or thimerosal. It's this other thing instead, or it's that. I mean, so eventually you just kind of say, look, they're safe. You know, I mean, they've been studied and used in millions of people. We know what the side effect profile is, and here's the real information. But the thimerosal misinformation, and you know, arguably even our response to it, you know, I think the health, you know, community tried to get ahead of it and say, well, this is our problem, so we'll just remove thimerosal, and we can do that in the U.S. We don't need multi-dose vaccine bottles because we can do single use, and that, you know, when we do that, then the problem will go away, and it, you know, and it wasn't anybody's intent, but I think we might have kind of fed the beast a little bit with that.
With that. Okay, we have a question, I think, that's just come in.
Can you tell us a little bit about age groups that are protected based on when they were born and if they have received the vaccine when young, adults as well?
For adults, if an adult has had 2 doses of the vaccine, this is MMR vaccine, so I'm talking about measles here, which I assume the question is relating to, then they're protected for their life. So 2 doses of MMR protects you for forever. So if you're 1 year of age and you're eligible for your first dose of MMR, then assuming there's not measles in your community, you're considered, you know, to be fully protected until you're eligible for dose 2 at 4 to 6 years. On the other hand, if measles is coming into your community and your public health officials are saying, hey, give that second dose earlier, then you're going to want to give dose number 2 to get to that full lifelong protection status as long as more than 28 days has passed since dose number 1.
So if you're a year or over, you have a chance to do all this with vaccine. If you're under a year, between 6 months through 11 months, then it depends on what the risk is, and it depends how long it's been since you've been exposed. And those two tables that I mentioned that are in the slides, they're also in the Red Book, or versions of them are in the Red Book. Those are great resources to go and really quite rapidly, find out where you are in that time frame and what is an option available to you. If you're under 6 months of age, then you can't give the MMR. It's a live vaccine. You can't give it. And hopefully you're going to have maternal immunity, assuming moms, had been vaccinated themselves, or if they're older, maybe had or came from a different part of the world, had measles themselves as a child. So hopefully the transplacental passage of antibody will tank up the babies, and they'll have that protection during the first 6 months of life. Now, I'll also mention that, and this is a bit anecdotal, but these are reports coming out of Canada where they've had those 5,000 plus cases last year. They are seeing some what look to be in utero cases of measles, and they've even had in a 3 and 4 month old newborn, they've had SSPE. I think. Now, I've not seen the data on that, but a colleague a pediatric infectious disease colleague in Canada has told me that she's been involved in the care of at least 1 or 2 of those babies. So we do need to be mindful as well of in utero exposure and what that can do. That's tangential to the question, but I wanted to put it out there.
Would you please share again your model about how long it will take for the United States to see a resurgence of measles?
Well, it depends where you are in the United States. If you're in Utah and Arizona, I'd say like tomorrow. If you're in Birmingham, it could be next week, could be next month, it could be next year. But I will say that as measles, let me use more optimistic terms. If measles establishes a foothold again and has local spread across communities across time, and we lose our status of not having measles transmit that way, and it becomes endemic again, it will go everywhere. And so none of us will be safe. How quickly that happens, I don't know. But I will say that, that West Texas outbreak was pretty big, and the Spartanburg outbreak was pretty big. And the West Texas one was in an area where they had a lot of mistrust of health professionals. So what we saw out there was probably the tip of the iceberg in terms of numbers of cases. Can't prove that, but that's likely, I think. So that's the official answer. My real answer to a really good question, I'd say over the next couple of years we're going to see it coming back.
Okay. And this one, they say they may have missed this on a chart, but how long does the physician have to provide the IVIG or IG after the patient's exposure to measles?
If you get out beyond 6 days, then gamma globulin isn't going to do any good for you. And if you're within 6 days, it may not be the approach to use, but that depends on age, on immune status, and so forth.
Okay. And then what steps can daycare providers take to help prevent the spread of measles and protect children, staff, and families? Are there recommendations that child care staff should follow and discuss with parents? That's a really good question. It probably is more of a health department question because there's regulations that are involved with daycare facilities, child care facilities. I think so I'll leave it to the experts, to address that. I would say that if I ran a child care facility, I would want to make sure everybody who works there is fully immunized, and that includes against pertussis and all the other vaccine preventable diseases, hepatitis A and so forth, certainly measles. And I would want to convey to parents how much we value vaccines. Because I think the more parents hear a lot of noise out there on social media, and the more they hear the voices of people they respect, and I sure hope they respect somebody in a child care facility because they're leaving the most important person in their lives with that person for hours each day, or on days that they're doing that.
that would be an opportunity to share values.
I'm sorry, but I think we're going to have to conclude our program today. We are just delighted to have you here. The information has been incredibly valuable, and we thank you for coming out of your busy schedule. And we thank you all for watching the program today. Thank you very much, Dr. Kimberlin.
Delighted to be here, and thank everybody for what you're doing out there.